Okay, well, good morning and welcome back. My name is Peter Newman. I'm from the Post Medical Center here in Boston. I'm very pleased to introduce the next panel, Valuing Non-Fatal Health Risk Reduction. If you thought valuing mortality risk was challenging, now we're going to get to even more challenging. Very pleased to introduce Lisa again. Lisa Robinson, Jim Hammond are the authors of the paper. Discussants, we have Mark Hickey of the University of Central Florida and Mantra Arun Chavan from Mahidol University in Thailand. So, same format, we'll have speaker discussants and then questions. So, Lisa? Thank you, Peter.
We're working on the agenda for this. We're thinking you're going to really get sick of seeing me and Jim, and we should really split up all the times we're on the agenda. But this particular topic is so close to the topic of valuing mortality risk that it really didn't make sense to split it up. So I hope you'll bear with me and listen to me one more time. So I'm going to talk very quickly about the concepts and context for valuing non-fatal risk reductions, briefly talk about willingness to pay, and then talk about some proxy measures, some ways of approximating these values when we don't have good primary research. So everything you just heard before, just keep it in the back of your mind because the concepts for valuing non-fatal risks are exactly the same. We're interested in values per statistical case because we're thinking about policies that reduce the likelihood that you're going to get sick or going to get injured. We're not talking about something that prevents injury or death occurring to you with certainty. We are interested in measures of your willingness to pay for reductions in your own risk. We use revealed and stated preference methods. And because we usually don't have enough time or resources to do new primary research and benefits transfer. It's a huge issue here, though. I mean, the last panel may have persuaded you that we have a problem and that we don't have enough PSL studies in low and middle income countries. For non-fatal risk, we don't have enough studies even in the U.S. This has not been an area of substantial investment for a number of reasons. That's probably a conversation we could have offline at lunch. I won't take up your time now, but there are not a lot of these studies. I wish what I could do is send you to a criteria-driven review of all of the research that had ever been done on willingness to pay for non-fatal risk reductions. Unfortunately, I can't. It hasn't been done as far as I know. We do footnote in the paper some sources that look at some segments of this literature that are hopefully useful places to go. But I think that you as analysts will probably have to do your own review of the literature to see what you can find and the health effects that are of concern for a particular analysis. This does mean that you'll be in a situation of case decision making. You'll have to use some judgments about what constitutes a high quality study and whether or not the studies that you found are suitable for the policy context that you're evaluating. Most of the time, you're either likely to come up with nothing that seems relevant or studies that may be relevant but have some significant flaws. So what most people do is to turn to some sort of a proxy measure. These methods are imperfect. They don't entirely align with what we're trying to measure in benefit cost analysis. However, they are widely used and give decision makers and analysts some sense of what the values of these outcomes might be. They include the direct and indirect cost of illness. You'll notice later in the slides, as well as in the paper, I use the word averted costs instead. In health research, the term cost of illness is usually interpreted as meaning medical costs associated with treatment and other aspects of the illness and lost productivity. But when we're talking about cost, we could be including other things in addition to those costs that are averted by the illness or injury, by preventing the illness or injury. The second thing we see a lot in the literature is the use of quality adjusted life years or disability adjusted life years. I'm not going to spend any time talking about what these measures are because I'm assuming that most people in the audience are familiar with them. However, we do have very brief discussions of the concepts in the paper, and Peter can answer any question you have about this, right, Peter? Because Peter just finished chairing the second, or co-chairing, the second panel on cost effectiveness in health and medicine, which made some very specific recommendations about how to deal with these measures, and also has a large database of DALY studies. Anyways, when we go to cost benefit, these are not monetary measures, so when we're doing the cost benefit analysis, we need some way to monetize them. What is commonly done in the literature is that they're valued using a constant, usually a value per statistical life year, although you could instead calculate a value per QALY, or a valuation function. What's not commonly used, but we've been working on developing, is the valuation function, which adjusts for characteristics of illness or injuries. The asterisk is just to say that, like other willingness to pay measures, these tend to focus on our own willingness to pay for changes in our own risk. And in many of these studies, we don't take into account the costs that are incurred by others. And so if that's the case, and those costs are not included elsewhere in the analysis, they can be added. So averted costs. These measures are not consistent with the theory that underlies benefit cost analysis. These are incurred costs. They're not willingness to pay. Incurred costs may be less than willingness to pay, depending on market forces. They also may be more than willingness to pay, particularly if somebody else is doing the paying, like your insurance company. These are also costs for something that's already occurred, not our willingness to pay for something that we might receive if a policy is implemented. And perhaps most importantly, it doesn't take into account the effects of the illness or injury on our quality of life and pain and suffering. In the U.S., when we talk about this in the U.S., I usually say something a little bit different here because there is a lot of empirical evidence in the U.S. But when we go to these low and middle income countries, the data available really varies. Jim and I and some other people who are actually in the room have been working on guidance on estimating medical costs and benefit cost analysis in the U.S., focusing on opportunity costs, but that guidance is not very helpful when you go to low and middle income countries because the data are very different and the issues are very different. The other issue is that a lot of these cost of illness studies look at incurred costs in a particular year for all the cases that were present in that year. When we're doing benefit cost analysis, often, not always, but often, what we want to know are lifetime costs associated with preventing incidents of a case. So that requires, ideally, a different type of data than what's often in this literature. So there's some challenges to developing these estimates. There are lots and lots of QALY and DALY estimates out there. Peter can tell you where to find them. These estimates are not necessarily consistent with theory. They look at the trade-off between health and health or health and longevity, not between money that you could spend on health versus spending on other things. So what we try to do, or what we hope to do, is monetize them using a measure that does reflect those trade-offs between having this change in your quality of life and spending the money on other things. Usually when we monetize, we use this constant VSLY that's calculated using very simple assumptions. We talk about that somewhat in the VSL paper, and Jim talked about this a little bit in his slides. The available research suggests that not only is the value of a statistical life year for mortality risk not constant, but the value for a QALY is also not likely to be equal to VSLY or constant. We expect that like for other things, our willingness to pay for a change in these risks depends on how severe it is, what its duration is, and other characteristics of both ourselves and the risk. The work of evaluation function, by which I mean an equation that has measures of things like duration and severity in it, allows us to adjust the value of a QALY for the characteristics of the illness or injury. It would also allow us to adjust the value for the diverse preferences of people who live in different countries or have other variations in their characteristics. In the interim, all we can really do is use these rough proxies, but it's very important that we discuss the implications of uncertainty and what it means for analytic conclusions. So what do we recommend? Well, what surprised you to know that we think you should start off by looking at the willingness to pay literature and see if you can find some good studies. And if you can find some good studies, please use them. There's a discussion in the paper of the benefits transfer framework, which really includes 4 steps. The first is to be very clear about what the policy outcome is, what health effects are being reduced, what the populations are, as comprehensive a description as you can get. Then to search the literature for studies that look at the same or similar health effects in the same or similar contexts. Review them for quality and applicability. Quality meaning adherence to best practices for the research methods that are being used, and applicability meaning the similarity between what's in the studies and what is being addressed in the policy context. And then transferring the estimate. This might be transferring a range. Jim showed you an example of what we recommended in the case of the VSL. It might mean transferring a point estimate, although we would generally not recommend that because there is always uncertainty. Using meta-analysis, using expert elicitation, there's a number of different options there. So we're expecting that in most cases, at least today, you're going to have trouble finding some good willingness to pay studies that are applicable to the policy that you're working on. So we suggest using monetized QALYs or DALYs as a proxy. There's lots of guidance out there about the best way to estimate QALYs and DALYs, which we can send you to if you're interested. And then the next step is to estimate the monetary value, which in the paper we suggest deriving from the VSLYs that excuse me, that result from the recommendations in our VSL paper. Then we can add the costs incurred by third parties as long as they're not counted anywhere else in the analysis. You've got to be careful that they're not included in the willingness to pay measure or estimated elsewhere, and address uncertainty. So over the long run, it was funny that the question about resources came up in the VSL context, because I was trying to imagine what a research program would look like that tried to address all the different non-fatal health effects that we care about in all the different countries that we care about. It would be huge. It would take a long time. It would be really nice to think about a way to do that where we do what the panel before was talking about, where we have some sort of standard survey that can then get adapted to different health effects in different contexts. But we're so far away from having the numbers that we really want. We need to continue to think about what to do in the interim. And I think that the valuation function, in my mind, is more tractable because we have QALY and DALY estimates for so many different health effects. We could figure out a different way to determine the monetary, or better way to figure out their monetary value that would allow us to cover a lot of the landscape. Largely through work that Jim's been doing, we have some ideas about how to do that for QALYs in high-income countries. We need to think carefully about what that means for valuing DALYs, since those are more frequently used in global health, and how to take into account the fact that preferences in low and middle income countries are likely to be diverse and vary from what we're seeing in these higher income countries. And that's it. Thank you.
Well, thank you very much, Lisa. So now we have two discussants. Why don't we start first with Mark?
Hi, I'm Mark Dickey, and happy to be here and happy to discuss this paper. There we go. So the paper I very much enjoyed reading. We were asked as discussants to address a few questions, and just to get those accomplished here at the beginning, I think it's a really impressive effort to develop guidelines for benefit cost analysis, especially applicable to low and middle income countries, or looking at non-fatal health effects. It's the paper, as far as I can tell, is technically accurate, and I think the methods are practically applicable. And that's certainly important given the lack of data. So the problem that's posed in the paper is simply that it would be useful to be able to apply benefit cost analysis more broadly to value non-fatal health effects. And how would you go about doing that? The problem is that even if you take a high-income country like the United States, there's really relatively few willingness to pay studies for non-fatal health effects. And yet there's so many different effects and so many different populations to focus on that I think, as Lisa was pointing out near the end, waiting for or trying to accomplish the research agenda to accumulate all the willingness to pay studies you'd like to have. Certainly in low and middle income countries, that would be a long time coming. And so the paper proposes to approximate benefits using health state quality of life index like QALYs or DALYs, and applying to that a value of a statistical life year. And I think what is an element that's useful about that, in addition to QALYs and DALYs being widely available, is that both health state indexes, the way they're usually measured, they're an expression of people's preferences. They're collected from preference-based surveys usually. And the VSLY is derived from preference-based studies. And so if we're trying to estimate benefits in a way that represents preferences, we at least have a start here with two preference-based measures. So the benefit estimate is, to make it just to, yes, the benefit estimate, to simplify down from some of what's in the paper, is take the value of a statistical life year. In practical terms, you're probably going to treat it as a constant, and you're going to apply it to the change in QALYs or DALYs that would be achieved by some policy or program. And that's practically applicable, and I think it's a useful proxy. I'd like to just take a moment, though, to question how far off might that be from a real estimate of willingness to pay from the people affected. And one problem is that QALYs really are not consistent with economic theory on valuation. They're not consistent really with empirical knowledge of what we know of how people value health and how they value duration of health states. And this is pointed out in the paper. So I'm not really offering anything that the authors don't know in this case, but just commenting on what's there. A constant value statistical life year, Lisa pointed out, is probably not an accurate representation of people's preferences either. And there's a recent paper by Jim, I hope I'm not misinterpreting it, that taking any life year measure and applying a constant value to it is just not going to be a consistent way of measuring benefits. And so just to take one of those, the first of those, and to look at QALYs, really, as I think this audience probably knows better than I do, QALYs are based on some assumptions of constancy that really toss out the idea of diminishing marginal utility or diminishing marginal rates of substitution that give us our usual convex indifference curves that we might think would exist between duration of a health state and the quality of life in that health state. And instead, we get a linear, essentially, trade-off between these two things, so that 2 years with half a QALY is the same as 1 year with a whole. 2 years with half of a quality of life index of 0.5 is the same as 1 year with a 1. So that's, a little bit troubling, I think, in relation to what we normally think of as people's preferences. And those assumptions of diminishing marginal utility and diminishing marginal rates of substitution, those have been retained for so long in economics because they do seem to be consistent with people's choices and with their actual behavior. I don't want to make the ideal be the enemy of the good here, but if I just took the most negative way I could look at this is that we have two measures that are not entirely consistent with individual preferences, a constant VSLY and a QALY or DALY measure. And then we're combining them by multiplying them, which is not really consistent with preferences. And this is how we're going to get a benefit measure for a procedure that should be consistent with individual preferences. And I would like to know, how far off might that be? And how well is this going to work out for us? And I think that partly depends on what is the practical alternative to be considered. And many times the practical alternative is either no valuation or it's going to be a cost of illness approach. And I think that here we're accounting for preferences with the approximation. And so that I would think would be a big improvement over just illness costs. At the same time, if the proposal were to apply this, let's say, in the United States, well, I'd want to know a lot about just how far off might this be from a direct measure of willingness to pay. And I'd want to see those comparison studies that would apply this methodology compared to primary research on willingness to pay and just see how good this approximation is. In the meantime, I think perhaps some simulation or since we do know at least a little bit about the curvature of preferences in life years and in severity of illness and duration of illness, maybe some simulation work in the interim might be useful to see how far off we might be from a primary estimate of willingness to pay here. Okay, thank you.
Okay, yeah, that's right.
Okay, good morning, everyone. Again, I'm so happy to be here. And I think I'm from Mahidol University, Thailand, which is one of the low and middle income country. So I think it's a good reason that why you have to listen to me too. Okay, so we were asked to comment on this issue. First, I think this is a well-written and leader-friendly guideline. It's easy to understand. And it's quite useful for our stakeholder and policymaker. And I think the paper, how to put the monetary value for the non-fatal risk or mortality risk is very challenging. And also it's even more challenging is because the method is intended to use globally, not to use only in the US or high-income country. So most of my comment will not be more on will not focus on not on the methodology because I think the author know well about the limitation of each method and that they decided to use this one. So my comment would be like how applicable for the recommendation to the low and middle income countries. So I think for the first recommendation that the author recommend like the use of willingness to pay for non-fatal risk, and they recommend the high quality willingness to pay with the relevant risk. I think this is quite difficult to have the evidence on the willingness to pay. Even you mentioned that even in the high income country, and I think even if you have the high quality of evidence of willingness to pay, the transferability is not that easy by just using income adjustment. Because I think the lower and middle income country and high income country, they are not only different by the income, they are different in other way as well, like how we perceive the risk, and also like the healthcare finance, the health insurance structure. For example, in Thailand, even though we are upper middle income country, but we are on like universal healthcare coverage. Most of the medical costs were borne by the government, so it's like the other way around. So I think it's not just easy by you just use the income adjustment. So I think my comment is that if you want to transfer the result from one setting to other setting, you have to think that you have to transfer from quite similar setting to the other setting that are similar enough, not just only adjust for income. And the other point is that the guideline recommend the monetized value of the QALY. I think this is interesting. I think in this a value of a QALY, the guideline recommend that it should be based on the VSL, which is estimate from the mortality risk reductions, and with a big assumption on that one VSL, the VSL is constant, and in fact everyone and the author know that it's not constant, and also they assume that one VSLY equal to one QALY, which is like maybe not hold true because everyone is not in the good health. And I think that besides the as I mentioned before, either you use this one or the other method, there will be a limitation. And I think the author choose to use this one. For applicability in the low and middle income country, I think it's quite difficult because we don't have a lot of VSL study or willingness to pay for QALY study in low and middle income country. Right now, what we use the human capital approach to value the mortality risk or something like that, and we use awarded cost to calculate the benefit for non-fatal risk reductions. And I'm gonna skip this one. It's a small point. And okay, I think the other thing beside the methodology that you have to concern is like the ethical issue. It will be difficult when you try to put the monetary value for health or for mortalities. I think that the guideline should mention something that the benefit, the monetary benefit that you value here should not be like used as a single criteria to determine the resource allocation across different countries. For example, that I give, we have like 3 situations. We have 2 countries, country A and country B. And we have 2 programs, to A and B. And each program costs the same, $5 million. And if you're looking at the benefit in terms of QALY gain, they are different. Because like the last one, the implement program A in country B, we got the least QALY. Why, if you implement program A in country A, you got the largest QALY gain. But because the country have different income, and if you put the income to value the health, you can see that because of the value of the QALY are different across country. It might be meaning that for the same country A, it's clear that you should implement program B instead of program A. But if you want to allocate resource across country and you use the benefit that you derive from this estimate, this might be leading that you're going to fund the country B and program A or something like that, even if the QALY gain is the lowest or something like that. So I think there should be some ethical issue, or the guideline might put something, for example, that is not intended to use only as a sole criteria. There are other factors also that they have to think when you do the resource allocation across different countries. Oh, I think the last one, if the guidelines will be adopted, I think there will be a lot of study on willingness to pay per QALY or VSL conducting in the low and middle income country in response to this guideline. So it might be nice that you provide how the clear method and like standardized questionnaire or something like that, so we can conduct the study with high quality and comparable to study in the near future. I think that's it. Thank you.
Okay, thank you, Lisa and Mark and Montserrat. Let me ask you to come up if you would, and we'll begin our discussion and Q&A. And Lisa and Jim, are you coming up to this too? Yeah, we probably could use you. Let me first give you, Lisa and Jim, a chance to respond to what you heard from the discussants, and then we'll open up.
I think we should maybe just as a point of clarification that yes, I'll pay for this right you guys brought up that I actually wrote this paper beforehand, so it's about what VSL is. We don't The DSL estimates, our population average estimates, they include both healthy and unhealthy people in the population, and the methods of extrapolation that we talked about in the DSL paper are intended to take into account at least the income differences across countries, and we do recognize there's lots of other differences. Another point too, which I think gets to your last slide or your second to last slide, is that as I said on next we realize that
very consistent with preferences. Why inconsistent? Why do we think it's going to be good? And how bad might it be? And the answers to that I can put forward are I, with a colleague county manager, did 2 studies in the U.S. where we elicited qualities for short-term and long-term non-fatal and then the DeShazo and Karen DeShazo study that you put out that Anna referred to earlier also elicited lots of willingness to pay estimates for various forms of morbidity risk reduction. And one way to summarize what we get out of all those studies is that the elasticity of willingness to pay with respect to the duration of the illness avoided is something on the order of 0.2. So if you double the duration, willingness to pay to reduce the risk of that thing would be 20% higher. And the sensitivity to severity as measured by quality in my work anyway, is on the order of 0.3. So it is, as you suggest, very sharply diminishing marginal willingness to pay. But is that, to go back to point B was pushing on these plausibility tests, is it plausible that willingness to pay really diminishes that sharply, or is it problems that people don't really have sharp preferences, or our tools for eliciting those preferences are not sufficiently accurate?
Great.
Okay. Just in your response to that, whether we can believe those.
Those would be consistent with the information that I've seen on the elasticities. So they do seem awfully low. And even with those numbers, it's hard, I think, to summarize across the variety of morbidity types that people might have. So I don't know what the elasticity is, I guess is the answer. Yeah.
Okay, so papers are now open for discussion, so please state your name and affiliation. What?
I have a question. So the question is really about cost of illness and not using that in lower income countries, or the feasibility of using the cost of illness in countries instead of using going to the route of valuing policy.
Yeah, can you speak up a little bit? We're having trouble hearing.
Sorry. So the question in the direction of valuing policies instead, but still, conventional proxy that we use for non-fatal illnesses generally has been costly. And I guess the question is what have you found in terms of research looking at what I would expect, having lived in one country, worked in one country, is that the healthcare utilization rates are very low and very variable. And so that I would expect that cost of illness estimate would be more severely underestimating willingness to pay to reduce risk of illness than would in higher income countries and higher healthcare. And I'm just wondering what you found in the literature on that. And the question is what you found on that. And then so I'll make a comment. So the comment is really on valuation qualities, and I just wanted to bring in some experience from a recent study that was has just been completed by the UK there's kind of concern among developing countries whether can we do something better than cost of illness, because we know we're not capturing this utility of the illnesses. So the thinking was, if we can develop in this kind of limited area where we have a limited range of illnesses, studies that would value EQ5D, that we could then use that to carry over. And so the idea was to develop EQ5D characterizations for the range of illnesses that we're illnesses. So that's diarrheal illnesses, kidney failure, some neurological conditions, birth defects. Euroqual 5 level, 5 dimension. It's a major, one of the major quality instruments that was developed in the European Union, and it's a quality instrument for which in the U.S. we have population surveys to gather people's valuation of it. So we have a preference-based set of weights that we can use to estimate the values here. So they're used in the U.S. and they're also used in Europe. Okay. So the idea what the EQ5D does is characterize health states by identifying different dimensions of health. How does this illness affect your mobility, affect your daily living, how much pain, psychological distress, etc. It does it with now a 5-point scale. But it's the kind of thing that when you look at a choice experiment, the kind of thing that you could present as a choice experiment. You could say, here's an illness, you could characterize different levels of, okay, if I get this illness, I'm not going to be able to walk around for a certain number of days, so I'm going to be in this level of pain. So the thinking was that we could really develop a joint stated preference choice experiment study to study them. What we found was, what that study found was that I had a very difficult time getting their head around that kind of choice experiment. And then in fact, the study had to revert back to a more conventional stated preference kind of description of the illness. More verbal description of this is what we're going to feel like in these states. And so that was something we learned about the ability to do that, but we also still in that study, but in that study there's also still, a side by side those data descriptions and so it suggests that it can be done, but we have some difficulties, and I still hold out hope that perhaps there would be a way of developing a preference-based data preference kind of study that would allow us to value the standardized quality instrument and that quality instrument can be applied. But I'd still like to hear
Okay.
Lisa?
On the first question, there are an enormous number of people sitting in this room who have done more healthcare costing in low-income countries than I have. You want to represent them and say what you have?
No, but if somebody else here wants to do it, I mean, I'll keep going there.
I'm on the second. You want to address that?
Well, I think this is sort of the point Mark was making, that surveys can be done to value qualities or components of them, like with quality weight or EQ5D dimensional attributes. And one of the ones I did does that, and the results are pretty inconsistent with willingness to pay. And the willingness to pay is a very flat function of duration and of severity as measured by qualities. And then the real question is, so what we're after is measures of people's sort of informed reflective preferences. And the question is that what these surveys are getting us, or is forcing values to be more sensitive to duration of illness and to severity as measured by things like quality, actually getting us to preferences that are more consistent with what people really believe hard enough to figure out what they really need.
Okay. Somebody coming. Again, state your name and affiliation, please.
I sort of have a related question to the previous one. The first one is more of a question, the second is a related comment. The first question was something that I think design engineers have been constructive about when they added the incurred third-party costs to the monetized quality. A thought that comes to my mind when I think of monetized quality is usually starting with what you actually have as default, your proxy is your average VSLY, which is willingness to pay. So when you're thinking about willingness to pay from an individual perspective, we're not talking about the ability to pay, we're talking about willingness to pay. In a way, the individual is already thinking about who else might be paying for the medical costs. So it may not just be what the individual is paying, but probably takes into account the third party payment. So I'm not really sure adding the two makes sense. It sort of be inconsistent approaches, bringing in the direct medical cost of illness along with the willingness to pay the future. I'm not sure that works. But you must have thought about it and come up with a solution. So like your thoughts on it. The second part is sort of a related comment. When we have dealt with it at the CDC, oftentimes when we do cost of illness studies, they want to estimate the economic burden of say, smoking or even some economic burden of Legionella or a foodborne illness. Oftentimes we have the direct medical cost of illness, and then when it comes to the indirect cost of illness, oftentimes we relied on the human capital approach because even though the programs would like a larger number, they would look at the VSL and say, no, we're not going to, this is way too large. So why don't we rely on the productivity loss tables, right? Oftentimes we've done that. So whenever you see an economic burden of illness coming up to CDC, it uses the direct medical cost of illness along with the productivity loss table. And that was something that was suggested by Mark Hickey that becomes, I think also the previous commenter on the country study. But one little flag that I'd like to raise with that is when it came to doing regulatory impact analysis, which is comparing what public health interventions with FDA interventions, we felt human capital approach would put the public health interventions at a, they make us undervalue what we're doing. So then we went back and relied on VSL and VSLY because it gives us a common benchmark. And so, like for example, if you use the human capital approach, you're going to be using a value of life years, which is probably going to be 5x or 3x times less than when you use the VSLY. And I saw it particularly potent when I was doing a study in Malawi, and it's sort of, it was a cost effectiveness study related to health intervention, cardiovascular disease intervention, and I thought of using the human capital approach. And I said, this really work because if I look at it from a country perspective, it makes sense. But when you're looking at it from the donor perspective, it's going to usually undervalue, what the value of life years off might be because you're looking at it from the income of Malawi, which may not, compare. It would be better to use something that's broader and does not undervalue.
Okay. Who wants to take a number of questions?
Well, I'll just say, so we tend to think human capital and cost of illness will undervalue because it leaves out the non-market components of something. So it's a useful lower bound, perhaps. And then when we add monetized qualities or something to the other components, a key issue is whether these costs are internalized by the person. So they might include that in their response to state preference questions, or external, paid by insurance or government. And so it seems pretty legitimate to add the external costs to the private benefits and to think the private costs might be embedded in the phone.
Others on the panel?
I'm not sure if this is possible or not. If in the guideline you recommend doing an approach and avoided cost as the lowest estimate, and then the one that you recommend can have
So one thing that we do at FICCAL is about how the social programs can be translated across contexts to help populations that may be facing similar constraints or similar circumstances, but might not be in the same country. And so I'm wondering if there's any room to, instead of looking at country by country basis, I think this point has been brought up a few times already, looking at similar populations whose preferences might be shaped or constrained by similar circumstances, even if that's across different countries. And given, assuming that we have data like we've been talking about, is that something that you're thinking about?
Yeah, I feel like you just encapsulated the whole story of my professional life. This issue of what's similar and what's not is something that Jim and I have debated in every single one of these reviews we've done. There's several other people in the room who have worked on these reviews. And we used to think, okay, so maybe we should leave out Asian countries because we think Asian culture, we're looking because Asian cultures are very different in the U.S. And then you think, wait, what percentage of the population in the U.S. is Asian? I think, I don't think there's an easy way to do that. If you look across the different reviews we've done, we use different ways of trying to get at what's a similar population. None of them are entirely satisfying, which is why I keep coming back to the fact that we really need to go out and do more primary research because, all these things we do to try and simplify things really are oversimplifications. It'd be nice, like I've spent a lot of my professional career scratching my head and saying what's similar, what's applicable, and I started to think, I took all that time I've spent scratching my head, went out and did some new studies and really tried to understand the preferences in these different populations, different countries, different things. Like, I know that's not a satisfying answer, but I think it's the reality.
So I think it's a great research question to see how preferences differ in different societies and what factors tend to be responsible for that or be associated with it. Because in our recommendations, we're saying adjust for income. We're pretty confident that matters. We have some kind of order of magnitude sense of how much it matters. But it's very, very likely that a whole bunch of other factors matter too. We just don't know enough to say what to do about them.
Jim Newman from Industrial Economics. So, Montserrat, fair warning, I have might get some different question for you. So I'll lead in to give a little time to give. A couple years back, I had an opportunity that training evaluation of what health associated with air. And one of the things that struck me beyond the high-level technical skill of the participants, government and the nonprofit sector, was a very interesting discussion we had about the acceptability of willingness to pay estimates, particularly for matters of life extended into the fatal outbreak area. Among the participants, the difficulties that they had in trying to defend these sorts of estimates. So, the question I have for you actually relates not so much to your excellent comments, even the point which I took quite well, which is very differently. The context of the offhand comment said about how the basis of valuation in Thailand is actually human capital based on human capital based on mortality risk reduction. And I was aware from the work that we've done that there's actually a really high quality study, it's a case study in Thailand for values fiscal life. It has a scope test that Jim Hackett did, and some other interesting attributes that may or may not have been reviewed in your work. Anyway, what the question was, comments at all on the level of acceptance of willingness to pay based versus human capital based estimates in the context of your work, particularly in Thailand. I think that's very important for all the discussions we're having here. Even if we're satisfied with some of these recommendations, they're not tractable or acceptable in the context in which we're trying to apply them.
Yeah, it's a hard question.
I warned you.
Thanks. I we in Thailand we did a lot of research, even with the willingness to pay for quality or other things. But for the matter of statistical life, I think it's not quite popular, and I think it's quite difficult, but it's still doable. Which even though the context is different, we figured out how to do the interview or something like that. But I'm not quite sure about the policymaker how they're gonna accept the VSL because right now we use it by capital approach and like I mentioned we use like cost of units because we have a database that we can analyze how much is for like direct medical costs, and even though we have the database for the direct non-medical costs too, so we have a very good system on conducting the human capital approach and converted costs. But if we use VSL, we have to conduct a lot more study, and we, like I mentioned, we need a guidance of what should be the standard way to conduct the VSL, and of course, VSL results in the very high value of like other things. I'm not quite sure how it's going to affect the policy.
Did you want to say something, Ellen? Or, okay.
Okay, so there are a few minutes left. I'm going to pose a final question to the panel, which is, I guess, a version of the David differential question from last session, which gets at your question on this, which is the research agenda going forward. I guess I'd be curious, top of mind, what's the top priority here for the research for value on fatal risks? Hitting you with this question out of the blue, but really, what would you, did I say you were, I don't know, the Gates Fund? Where would you steer that?
I think I would love to see standard surveillance for valuing non-fatal risks that is easy to implement in a lot of different contexts, along with some guidance on how to adapt the survey instrument for differences in cultural characteristics and other things that affect how people react to these surveys, so that a survey could become a public good. You could all go out and do it in lots of different countries. We could compare results. You could each use your own favorite statistical model. We could see how things compare. And in that study, I would like to see some elicitation of willingness to pay per quality or dolly for the same health effects, that we can use the results of those studies to start building both the database of willingness to pay numbers for different non-fatal health effects, but also a bigger set of studies that we could use to come up with this quality or dolly evaluation function.
Okay, others?
Well, I think I would recommend something similar, which would be some primary research on willingness to pay health effects over in countries. Probably, I think it's difficult to do a lot of non-fatal health effects at once, and so picking up a few priorities would be very helpful. And then using that, recognizing that even if you did a lot of those studies, there would still be so many gaps in terms of other populations that you didn't study and other morbidity effects that were not studied. So I think that the WTP per quality or dolly, just to see how well does that work and how close does it come and which set of numbers do we find more complete.
I agree with it. We try to set up like the concept of risk reduction, because there are so many risk reduction, right? Maybe you can use the EQ5 as a situation to quantify the quality, like willingness to pay for quality using the EQ5 instead of the specific risk, because we have so many we cannot cover them all.
Okay, Jim, final word?
Like a sort of minor-friendly amendment to what Lisa picked up on my mark. Is I would be very interested in the characterizing the non-linearity between the money value and the quality value. So, there are a lot of people talking about, we just want to estimate the value of quality. And that's a badly framed question, I think.
Okay, with that, thank you all the panelists.